Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hello everyone, I'm the Millennial Mechanical Therapist, and today I want to continue that story I had about my patient with a potential lumbar anterior derangement. A quick recap: she came in after about 4 months of pain, and her history and her examination led me to believe that there's potential for both a posterior and an anterior derangement classification, at least provisionally. If you need more info, please revisit that first video and check that one out again. Today I'm going to continue with a follow-up visit. So I sent her home initially doing repeated flexion and lying, trying to either reduce an anterior derangement or expose a posterior derangement. The first follow-up visit that she had, she returned to me and she explained to me that her sciatic pain or her radiculopathy pain coming to that anterior thigh, she had not had that since she saw me this first time. She was very happy about that and said that she has a little bit of back pain right now, a little stiffness, and otherwise she's doing really well. However, she explained to me that after doing this exercise, whether it actually worsened things or not, or maybe she started focusing a little bit more on other parts of her body, she said that her neck was starting to hurt a little bit more, and she maybe just noticed it more. Now, I tend to believe that, the nociceptive input that the lumbar spine was giving her, now that that is coming down, she doesn't have that radiating pain. I tend to think that maybe she's just noticing it more because repeated flexion and lying really has no cervical involvement during the actual movement. So we reassessed the lumbar spine. Her movements were doing well. Her flexion increased because initially she actually had a moderate loss in that. So she now went from about flexing to hands to tibial tuberosity. Now she was fingertips to the floor, which is phenomenal. So at that follow-up visit, she asked me if I could start looking at her neck pain, and I said, sure, why not? Let's try it out. So remembering her mechanism of injury, which again was that body surfing accident where she had a hyperextension movement throughout her whole spine essentially, I said, well, let's listen to what you tell me, but I'm thinking probably another anterior derangement at this point. Now, her history for that was very similar to the lumbar spine. She didn't like sitting for long periods. She didn't like standing for long periods. Bending itself was painful, but it felt a little restricted to her, a little tighter than usual. Additionally, she reported that she had difficulty turning to the left. So we got some baselines there. I went through a quick neurological screen because she had a little bit of pain radiating to left upper trap, but nothing down either arm, and the neurological screen was unremarkable throughout. So what I had to start with was active range of motion flexion, essentially. So just repeated flexion. As she went through that, she kind of felt some of her symptoms relieving, but it wasn't a really quick change for her. So what I had her do was both hands coming up overhead, a little more overpressure, trying to really crank down on that potential anterior derangement, or at worst, we're going to expose the posterior derangement and be able to fix that. The more she did the overpressure version, the better she got, and her left rotation actually cleared up very well. She initially had pain during movement, and now she only had very minimal end range pain during that, or at that left rotation. So at the conclusion of that follow-up visit, I prescribed her to perform that cervical flexion exercise with overpressure, self-overpressure, 10 times every 2 hours, kind of following it up just with her lumbar exercise. And I told her, go home, do that, try that, come see me in a couple of days, and we'll see how everything goes. Now, when she came back, she said, my lumbar spine hasn't hurt at all since I saw you. I've been able to keep it completely gone, and I'm feeling great there. My neck also feels very good. It doesn't hurt to turn anymore. I don't get that pain into my shoulder up here any longer. and I'm just feeling overall much better. I was very happy with her progress so far, and we went through a quick reassessment, and she told me, however, at this point, she's starting to notice that she's having a little bit more pain kind of in her back, right in the thoracic spine there. And I said, heck, why not? Let's see if it's another anterior derangement. So what I had her do was kind of clasp both hands behind her neck in a position to almost lock her neck out. I wasn't too worried about her flexing too much because that was the reductive movement. That's her directional preference. But I really wanted to try to concentrate this movement to the thoracic spine. So what I had her do was try to sit up tall, but then just slouch from the thoracic spine, almost bringing her elbows down to her thighs. With that movement, we abolished the pain that she had. So in a nutshell, this patient presented to me with 3 regions of anterior derangement. She had a lumbar, a thoracic, and a cervical anterior derangement classification. When we found that reductive movement for flexion in each, we prescribed the appropriate amount at home, got her on a good home exercise program. In 2 weeks, or it took about 5 visits, she was pain-free and returned to working out, which was one of her main complaints when she came to see me initially. The takeaway from this, folks, really go through a thorough mechanical assessment and listen to your patients, because they tell you what's wrong. They really do. As always, move early, move often, and move to end range, because that's where the magic happens.